Hello, my name's Keval Patel. I'm one of the consultant urologists at UHB, and I've been asked to give you this talk about statistics for the FRCS urology exam. I've put stats for dummies, don't want to prejudge any of your statistical abilities, but I'm starting from the basics. So so hopefully you should be able to follow quite easily. Any problems, you can email me. Hopefully one of your colleagues will have an email address. I'll be happy to respond. Okay, let's get started. So, first of all, why do you need to know about statistics? And I guess the focus at the moment would be laser focused onto passing the exams, but actually, you do need to know about statistics to help you do your job. It's in the GMC guidelines that you need to be able to deliver evidence-based medicine. To be able to deliver it, you need to understand the latest evidence, validate literature, and hopefully design and contribute to effective studies to improve care for our patients. So we'll start off with the terminology, and let's just pretend you're starting as a new consultant in a new hospital and elsewhere, and you've been asked to sort out day case TURBT lists. So your first few cases in one day have got these following length of stays: 1 day, 1 day, 1 day, 2 days, 2 days, and 5 days. From this, you need to then report what your average length of stay was. Normally, this is a question that I ask whether you should use the mode, median, or mean. But for the purposes of this recording, I'll just explain the various items. So the mode is the most frequent number, and the most frequent number here is 1. The median is the middle or the mean of the middle two, in ascending order. So we've listed these in ascending order. So the middle will be 1.5 because you average, so you take the mean of 1 and 2. And the mean is just you add them all up and you divide by however many there are. So you can see in this example, the mode, the median, and the mean are all different. When describing length of stay, the most common way to do that is to do the median and then include a range. Yeah. So another important thing is to understand the difference between incidence and prevalence. Incidence is essentially the amount of new cases you have in a certain time period. Yeah. Whereas the prevalence is the total number of cases in a certain time period. Prevalence is almost always higher than incidence for chronic diseases in particular, but prevalence can equal incidence depending on the time unit used in acute diseases. Okay, more basic terminology. Understanding the difference between risk and odds. The risk is the chance of a poor outcome divided by the total number of outcomes. Okay, so if you had the next 100 babies and 60 of them were girls and 40 were boys, I shouldn't use had, if you counted the next 100 babies delivered at your unit and the next 60 were girls and and 40 were boys, the risk, in inverted commas, of a girl being delivered next, you would think would be 60 divided by 100, which is 0.6. That's different from the odds of there being a girl, which is 60, which is well, I don't like this example. It's not a poor outcome, but anyway, is the outcome of having a girl versus 40 for being, which is the inverted commas good outcome here. So that's 1.5. Okay, so the odds in this bad example of having a girl is 1.5. The risk of having a girl is 0.6. There's a difference, an important difference between risk and odds. So onto the meat of the talk then. Sensitivity and specificity. This is important. And first, I'd just like to break this up. So there's different statistics that you'll use for diagnostic tests and for treatments. So I've kind of put it in that order. So sensitivity and specificity is really important when you're discussing diagnostic tests. Okay, so the sensitivity is the ability of a test to detect everyone with the disease. It is, another way of saying that is the number of true positives detected by the test. And you can do that by getting the true positives and dividing the number of people the number of people who have the disease. So all of the people that were detected and weren't detected by the test. The specificity of a test is the ability of the test to rule out healthy people. Okay, and you can calculate this by getting the number of true negatives, the people that were definitely negative and were negative by the test, and divide that by the number of all of the people who don't have the disease. So the positive predictive value and the negative predictive value are built on the same numbers that you'll use to work out your sensitivity and specificity, just done in a slightly different way. The positive predictive value is the probability of having a condition given a positive test. Okay, you can work this out by getting the true positives divided by the number of people who tested positive for a certain disease. The negative predictive value is the probability of not having the condition when the test has come back negative. The NPV can be calculated by getting the true negatives divided by the number of people who tested negative for the disease. And this is a helpful diagram that we can use. And I've got some workings out here to show you how to calculate the positive predictive value, the negative predictive value, and some abbreviations here. So perhaps you could spend some time looking through this and working out yourself how to go through the sensitivity, specificity, and I think that will help you get a deeper understanding. Okay, let's move on. So sometimes when people are reporting their diagnostic tests, they'll talk about receiver operating characteristics or ROC curves. Different statistics you might hear are area under the curve. And yeah, so this is an example taken from a study into PCA3 diagnostic ability published by Schalken in 2009. And he's comparing serum PSA versus the PCA3 test and a combination of that of the previous two and trust volume to produce a third statistics, which is called LR here. Okay, so for the purposes of understanding the terms and what they mean, a really good test will be very sensitive and very specific. So there will be a line along this top grid here. So the area under the curve will be all of the curve, which can be expressed as 1 or 100%. A virtually useless test will be splitting the curve in half. So it goes from here, from this 0 to there, okay? So area under the curve here will be half of the graph, or half of the grids, and that's 0.5. So a completely useless test for its ability to detect PSA using prostate cancer using the cutoff that they've used, which I can't recall what it was, but this is almost useless, yeah, using serum PSA. They're showing that using PCA3 is better because it's got more of the curve under it, and LR is better still. And they've been able to show that there's a statistically significant difference between the two. I'll come more onto p-values a bit later when we talk about treatment arms, statistics for treatments. Okay. So moving on. So the next thing to understand or recap is that when you're thinking about clinical trials, there's different levels of evidence. Yeah. This is slightly just a broad strokes slide here. It hasn't got all of the detail, but generally speaking, a meta-analysis is by far the most powerful study, or form of evidence, I should say. And meta-analyses are conducted by pooling data from several different studies, often in the comfort of your own home via a literature search, to improve and achieve greater statistical power. The main disadvantage is that you can't overcome the weaknesses of each individual study. So you try and pick only the good studies, but even then there's always a weakest link. The next best thing is to have a randomized control clinical trial of high quality. So this compares two or more benefits by selecting people who get the benefit versus the control at random. There's several different ways that you can achieve that, and a level 2 trial is one which is high quality. Yeah, so you can have a poorly designed randomized control trial, but high quality things include ones that are blinded, where there's 80% follow up or more, and different markers like that. A cohort study, or non-randomized study, is an observational study and is the third level of evidence. In here, the sample is chosen on the basis of the presence or absence of risk factors, and you follow the patients or subjects over time and measure their outcomes. Okay. The fourth level is a case series where people often retrospectively just observe what's happened and describe that without the use of any statistics. And then the fifth level is expert opinion or mechanism-based rationale, that you understand, for example, why LH-RH agonists work and therefore you use them. It is an example. So I'd just like to recap that this is the broad strokes only. There are many caveats, and if you wanted to do further reading, you can do here at this link, which I'll leave up for a few seconds. Okay, so let's move on to the meta-analyses. So these are a statistical technique for combining results from several studies into a single numerical estimate. Like we talked about before, its utility or validity or usefulness depends on the quality of the studies on which it's based. Often, the results are displayed in a forest plot. This is an example of a forest plot. This specific example was taken from Sylvester's study of BCG and high-risk non-muscle invasive bladder cancer and progression. So there are a few things that I wanted to talk to you about. So the forest plot statistic is here. These are all of the individual studies that have been included. These are the number of events. We'll come on to that in a little bit of time as well. And this is the number of patients. Okay, and this is events, patients in the group that didn't have BCG, and events, patients in the group that did have BCG. Now, we'd probably see confidence intervals displayed here rather than the statistics that are here, which are a marker of confidence in some ways. The important thing in the forest plot is to see essentially whether the combined statistic, which is this here, it says the total here, crosses the midline, the thick line, because what they're measuring is whether BCG here has any benefit over no BCG here. And if the line crosses 1, then you can't tell the difference. They are equivalent. If this line does not cross 1, you can tell that it's either better or worse than no BCG. And there are several important characteristics of this mark, of each mark. So the length of the mark is proportional to the confidence that you have in this statistic. So if it's a really long line, you have a low value of confidence. And the thickness of the line relates to how many patients have been used. So for example, in this study, you can see that actually you've got a high number of patients used and you've got good confidence. Excuse me. However, the confidence interval does cross the odds of 1. So the chances of this being BCG being better for progression is not statistically proven in this study because the confidence interval crosses the odds of it being better and not being better of 1. Okay. So this is also a good example where all of the individual studies aren't able to prove whether BCG reduces progression, but pulled together, this meta-analysis can show that it does. And again, you can attach a p-value to this using a test statistic. And in this case, the p-value is 0.01 here. Okay. This here, which I was incorrectly circling earlier, is the test for heterogeneity. And this is essentially a test done on the individual studies to see whether there's a lot of difference between each, the patients pulled from each study. And you don't want there to be a lot of difference. You want there to be relatively homogeneous. Yeah. So the fact that this p-value is 0.5 is actually quite good.
So, moving on, a randomized controlled trial. So this highlights the difference between an experimental arm and a control arm. The hypothesis is always that the null hypothesis is that there's no difference between the two populations. The alternative is that there is a difference. So you're essentially measuring 1, an experimental arm population, 2, a control arm population. The experimental arm has something novel done to it. The control arm either have nothing done to it or have the standard therapy done to it. You can tell whether there's a statistical difference between these two populations by using a test statistic to generate a p-value. Yeah? And then the p-value can help identify whether there is a difference or not. A common misconception of the p-value is that it's showing that there is a difference. It doesn't. It's showing you the probability of the difference that you have observed being there because of random variance. Because if you do the same test 100 times, there is always a chance that you'll find a difference. Which is why why most clinical trials set the p-value to be quite stringent at 0.05, i.e. that there's a 5% chance that the difference that has been reported is there due to random things, and in actual fact that there is no difference in the population at large. So we talked about 0.05, and that's probably what most people understand of a p-value, but just wanted to let you know that actually you can set the p-value to whatever you like. I would suggest that this is the least stringent that you should expect to find in a study, but some genetic studies in particular use a p-value much lower. There's multiple caveats with generating a p-value, especially if you're using multiple testing for the reasons I've tried to explain just a few minutes ago. And if you are doing lots of different tests, you can think about other things like one-for-only corrections. And the most important thing is choosing the correct test statistic to generate the p-value in the first place. Because if your test is poor, the p-value it generates is going to also be poor and not applicable. Okay. Another thing about randomized controlled trials, modern studies are powered So what is power when you're talking about statistics? Power is the ability to reject the null hypothesis. So you want to design your study. Oh, I can't go back. Well, you want to design your study to be able to reject the null hypothesis and therefore conclude that there is a difference. This power is represented as a percentage. When the percentage is high, the power is high. When there is a big difference between population, a large study, or there's a lot of total events in the study, and we'll talk again about events in a few minutes' time. Okay? So having a big difference between your experimental arm and your control arm, having a lot of people in the study, having a lot of events that happen in the study can give you high power. I'm not a big fan of power in the kind of work that I like doing, translational work. It's often novel, and when funders ask for power, there's often nothing but hearsay to base your power on. But yeah, I think most people expect there to be a modern study to be well powered so that you have a good chance of proving what you want to prove.
Right, so let's put what we've learned into practice. So the PROSCAR long-term efficacy and safety study, or PLES trial, is a randomized controlled trial of the long-term outcomes of people taking finasteride or PROSCAR. So this is the treatment arm, and there's roughly 1513 patients in the treatment arm, and 1503 patients in the control arm, and the outcome they're measuring is retention. So if we, just as a note, this is the event rate. These are the number of events. So out of 3,000 people, 150 events were recorded, roughly speaking. That's one of the reasons that good quality studies in my subspec field, prostate cancer, are few and far between, because I suppose it's good that prostate cancer specific mortality is quite low and takes a long time to occur. So the number of events is really important, especially when you're calculating power and risk. Okay. So let's talk about the experimental event rate, which is 42 divided by the total number, which is 1513. So the experimental event rate is 2.8%. So that's saying that if you take finasteride, you've got a roughly 3% chance of going into retention in the time studied. I think it was 4 years for this study. And the control event rate is, so that's if you don't take finasteride, you've got roughly 6.5% chance. So it's worked out by the control events divided by the control total. So then let's move on to your risk reduction. So the absolute risk reduction is this, take away this, which is roughly 4%. The relative risk reduction is the event rate divided by the experimental event rate divided by the control event rate, which is 42%. And that's why people have moved away from talking about relative risk in reporting studies. You can mention it, but the strapline needs to be the absolute risk reduction, so that it doesn't seem to be confusing to a lay audience. Although this is true, I mean, it sounds like a really big number when actually the numbers are quite small. So for that reason, studies are now talking more about absolute risk reduction rather than relative risk reduction. Yeah, and I've mentioned that power and events are all related and the actual number of events is low. Okay, so one of the other things you might read about is number needed to treat, and that is 1 divided by the absolute risk reduction. So for here it's 26. So for every 26 people you treat with finasteride, you'll save one person from having acute urinary retention. Okay. Right. Another important point for randomized controlled trials is Kaplan-Meier curves, and this is basically for lifetime data, so they used to be called survival curves as a nickname, but actually they're anything. So you can have death, first metastases, progression, anything as the end point. And it's usually accompanied by a table. This is taken from my PhD thesis, where we're looking at people with muscle invasive bladder cancer and measuring a novel form of cell-free DNA in their urine. I think that was this slide, and seeing whether that's present after neoadjuvant chemotherapy. And the end point here is presence of recurrence of disease. Yeah. And on the x-axis, as with any graph, you talk about the axes first. We've got the days from the first TUR. On the y-axis, we've got the number of patients, or the fraction of patients who did not recur. So 0 days from TUR, no one recurred. By the end of it, quite a few people had recurred. So there's a few other things that you should mention when there's Kaplan-Meier curves. One, you want to choose a statistic which tells the difference between the two things that you're measuring. Yeah. And that's just expressed as a p-value. Again, we've talked about that. And often, and one of the criticisms in my thesis was that I didn't put, or of the paper, was that I didn't put a table at the bottom of it to record at what days how many people had events. But you can kind of see from the graph, all of the graphs will have a little mark every time that there's an event, or will have a step down if someone has recurred. Yeah. So this mark is that the follow-up has finished, and they're sort of nearly 500 days afterwards. Okay. Right. Again, with randomized controlled trials, or any trial really, you need to select a test to try and see whether your populations are significantly different. The key take-home message is to take the advice of a statistician. If you're not sure, don't guess. This is a table which tries to categorize what the variables are, what type of thing you're testing, to try and figure out, or help you figure out, which test you want to do. I'm not going to go into that in great detail. This is taken from a BMJ article, but essentially, if you're not sure, get the advice of a statistician or someone who does know. The last thing I wanted to talk about was bias. When you're talking about large trials, you can have either type 1 or type 2 bias or errors. Type 1 is common in large data sets, where the data sets are so large that even a small difference sometimes can result in a incorrect analysis suggesting that there's a difference between the two populations, and this can cause you to incorrectly conclude that there is a difference. It's a false positive, and it's, as I say, more common in large data sets. Type 2 error is a false negative, and it's common in small data sets where you don't have enough people to detect a difference that is really there. Yeah, so you're unable to reject your null hypothesis. Things that you can do to reduce bias are blind studies, use placebo responses, use crossover studies, and randomization. Okay, well, I hope that was all clear. Do feel free to email me or get in touch with me about any questions, and hopefully in a few years' time I can deliver this talk in person. Bye for now. Good luck for the exams.